Hey everyone, and welcome back to the Masterclass. I am absolutely thrilled to have you here with us for part 33 of our IPDRG deep dive. So, in part 32, we laid down a massive foundation by completely conquering the musculoskeletal system and joint arthropathy, really exploring how to perfectly capture those complex joint replacements. Well, today we're taking all that structural knowledge and basically wiring it up. We are tackling the super intricate world of ICD-10 PCS, nervous system, and spinal procedures. Let's get right into it. But real quick, before we unravel the complexities of spinal nerves and fusions, just a tiny reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Seriously, your support is literally what keeps this masterclass going strong. All right, here's our roadmap for today's explainer. We'll start with a nervous system overview, move into spinal decompression, tackle spinal fusions, look at neurostimulators and shunts, and then wrap it all up with a summary and a peek at our next lesson. Okay, let's kick things off with Section 1, Nervous System Overview, focusing on body systems 0 and 1. So, let's start right at the foundation, basically establishing our geographic boundaries. The second character in our 7-character code always dictates the body system. And the absolute first step in neurocoding, it's making this vital distinction. Body system 0 is exclusively for the central nervous system and cranial nerves. That's going to be your brain, your spinal cord, and those specific cranial nerves. On the flip side, body system 1 is dedicated entirely to the peripheral nervous system. Trust me, just grasping this simple 0 versus 1 split instantly narrows down your table choices and prevents some massive MSDRG grouping errors down the line. The absolutely crucial point here is that intent dictates your code. Let's look at 2 incredibly common spinal procedures that honestly look pretty similar but code completely differently. First up, a lumbar puncture, or what most folks call a spinal tap. This is performed to pull cerebrospinal fluid out. Because we're letting fluids out, the root operation is drainage, which is character 9 in the medical and surgical section. Now, contrast that with an intrathecal injection, where we are actively introducing medication into the spinal canal. We aren't taking anything out, right? We're putting a substance in. Therefore, this shifts our code entirely over to the administration section, which is section 3. Always ask yourself, what is the primary objective of the procedure? Moving right along to section 2, spinal decompression and discectomy guidelines. Diving into our first major surgical scenario, we're focusing on removing or shifting tissue to relieve pressure. When you're dealing with laminectomies, facetectomies, and discectomies, you simply must master the golden rule of removal. Here it is. If the surgeon is cutting out just a portion of a vertebral bone or an intervertebral disc, we code that to excision. That's root operation B. But if the surgeon completely removes the entire body part, say the whole disc, we code that to resection, which is root operation T. It all boils down to one question. Is it a partial or a complete removal? But what happens when the goal isn't just taking the bone or disc out? What if the goal is specifically freeing up a compressed spinal nerve? Well, that brings us to root operation release, which is character N. The definition here is super critical. It's defined as freeing a body part from an abnormal physical constraint. And guys, here is the coding rule you absolutely must burn into your memory right now. We code to the body part being freed, not the tissue being cut to achieve that freedom. To put that into perspective, take a carpal tunnel release. The surgeon goes in and cuts the transverse carpal ligament, sure, but the ultimate goal is to free the median nerve. So the body part coded is the median nerve. This exact same logic applies to spinal nerve root decompression. If a surgeon cuts away bone spurs or maybe herniated disc tissue just to free a compressed spinal nerve, your root operation is release, and the body part you code is the specific spinal nerve being liberated, definitely not the bone or the disc that happened to be cut. Let's move into section 3, coding spinal fusions, which uses root operation G. All right, this brings us to what is probably the climax of today's cognitive load, spinal fusions. To code these accurately, we really have to understand the core objective. Root operation fusion, character G, is specifically defined as joining together portions of an articular body part, meaning a joint, rendering it completely immobile. That's the key. We aren't repairing it so it can move better. We are literally locking it down completely. Now, securing these vertebrae requires immense body part specificity in ICD-10 PCS. When you code a spinal fusion, you can't just vaguely say spine. No way. You must identify the exact vertebral level, cervical, thoracic, or lumbar. And it doesn't stop there. You also need to specify the column designation. Are they fusing the anterior column, meaning the front part of the spine, or the posterior column? The approach and the column are both distinctly tracked in the code, so you've got to be precise. When you're actually navigating the ICD-10 PCS fusion table, that's 0SG for the lower joints, you really need to pay special attention to the sixth character column. That's the device. This table forces us coders to make very precise choices based directly on the operative report. Did the surgeon use an interbody fusion device, like a PEEK cage? Or maybe they used an autologous tissue substitute. That would mean bone graft taken right from the patient's own body. Or was it a non-autologous substitute, like bone from a donor? Your final code hinges entirely on the specific device left inside the patient to achieve that immobilization. So, let's actually build one of these codes piece by piece to really lock this logic in. Let's say we have Character 1 is 0 for medical and surgical. Character 2 is S for lower joints. Character 3 is G for fusion. For character 4, let's say it's 0 for lumbar vertebral joint. Character 5 is 0 for open approach. Character 6 will select A for an interbody fusion device. And finally, character 7, the qualifier, might be J to specify a posterior approach to the anterior column. Boom! 0SG00AJ. Every single character tells a vital piece of the surgical story. It's like a giant puzzle coming together. Okay, on to Section 4, Neurostimulator and VP Shunt Procedures. Take a breath, guys. We just conquered fusions. Now let's shift gears and look at specialized nervous system implants and routing devices. When it comes to spinal cord stimulators, or SCS, you've got a mandatory dual coding requirement. Yep, this isn't a single code scenario. First, you must capture the placement of the stimulator leads into the epidural space, which falls under root operation insertion, character H. But you aren't done. You must separately code the insertion of the actual generator pulse device, basically the battery pack, which is usually placed in the subcutaneous tissue. So remember, 2 distinct procedures, 2 distinct codes. Next up, let's talk about ventriculoperitoneal or VP shunts. These are often used for patients with hydrocephalus. Basically, a shunt takes fluid from one place and dumps it into another. Because it alters the route of fluid passage from the cerebral ventricle all the way down to the peritoneal cavity, it perfectly matches the definition of root operation bypass, which is character 1. And finally, Section 5, Summary and Next Lesson. Wow, what an incredible deep dive today. Let's lock in these complex guidelines with your core takeaways. First, always map your geography. Body system 0 is central, 1 is peripheral. Second, master those root operations. Excision is a partial removal, resection is a total removal, and release means coding the body part being freed, not the constraint being cut. Third, for fusions, remember that 7-character build requires exact vertebral levels, column specificity, and device identification. And lastly, always remember to dual code for spinal cord stimulators. You have officially conquered the nervous system, but our journey is far from over. Coming up next in Part 34, we are going to navigate the twists and turns of the ICD-10 PCS, gastrointestinal, and hepatobiliary system procedures. We're going to be looking at everything from complex bowel resections to intricate biliary bypasses. It's going to be a great one. You definitely won't want to miss it. As we wrap up, I want to leave you with our standard reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. And before we sign off, I want to leave you with a bit of a provocative coding puzzle to really test your grasp of root operations. So we just established that fusion renders a joint completely immobile, right? But what root operation would we use if a surgeon has to go back in, take down that old hardware, and attempt to restore movement to that previously fused spine? Think about the intent. Review your root operation definitions and drop your answers down in the comments. Keep studying, keep coding, and I will see you all in Part 34.